Opportunity to see all the amazing things that Dr. McGuire has done for the Academy. As many of you know, he's been a past president of the Academy. He's currently president of the foundation. He has received 3 of the major awards, the Robinson Regeneration Award, the Clinical Research Award, and this year the Gold Medal Award. Dr. McGuire practices in Houston, Texas. He started there, did some training at Baylor, worked through Emory, and then eventually wound back in Texas. He is a part-time faculty member of both of the UT programs in San Antonio as well as Houston. And I'm sure many of you know, just like our other speakers in this particular session, he's lectured internationally, published in many, many textbooks and many journals. So I don't want to talk anymore. It looks like they're set. Let's listen to Mike's presentation.
There you go. Thank you very much. I think Dr. Reynolds really set the stage well for my presentation and probably Massimo's as well. It is a pleasure to be here. I thank the organizing committee for the invitation. You know, I'm absolutely convinced that in the future none of us are going to be doing any passive surgeries at all. Everything we do will have an active component to it. And these active components will make our outcome more robust, more predictable, less invasive for our patients. And I think it's tissue engineering that's going to provide the active components that we're going to be using. I think of tissue engineering as kind of a broad matrix. And on one end of the matrix we have live cell therapy, and on the other end we have biologically active molecules like growth factors. And I'd like to share with you today a few studies that we've done using both of these novel approaches to achieve biosurgery. I think it's appropriate to disclose that I am a paid consultant for Organogenesis at this time. I have been a paid consultant for OsteoHealth in the past, but I always maintain complete control of the content of my lectures and the reporting of all data. In addition to that, when we get to the study with root coverage with the OsteoHealth product, I used a technique that varies from the FDA-approved instructions from use, and they asked that I include that in my disclosures here. So let's begin with the live cell end of the tissue engineering matrix. And you know, as you begin to get into this, we're really changing the way we think about grafting. And you almost have to deprogram yourself from what you expect a graft to look like, a graft to respond to, in the way that we've all been taught and the way that we've worked with grafts in the past. And as you move into soft tissue engineering, there's been 2 really kind of basic lines of research. People have looked at biologically based devices and live cell based devices, and they differ a great deal. Now, biologically based devices are basically just a biocompatible surface. And the one that most of us in periodontics are going to be most familiar with is acellular dermal matrix. You know, it's cadaver skin. They've removed the cells, leaving the collagen, the extracellular matrix protein. It is, in essence, an immunologically inert allograft. It will support fibroblast migration, revascularization. But basically, it's just a tissue replacement graft. It's a dead piece of tissue. It brings nothing else to the party. Very different from live cell-based devices. Live cell-based devices bring with them not only cells, but a whole host of cytokines, important for the inflammatory parts of healing and regeneration, important for angiogenesis. They bring collagen. They bring all sorts of extracellular matrix proteins that are necessary. And most importantly, theoretically, they can deliver this on demand. Dr. Reynolds mentioned that oftentimes you need a lot of different things going on at the same time. It's a cascade. It's not a simple event. And the exciting thing about this is we may be able, through these live cell devices, to overcome some of the challenges we've had in the past. You know, we've taken very potent growth factors and we've placed it in the defect and waited for magic to happen. Oftentimes magic doesn't happen. Why is that? Well, how do we know that that growth factor actually got to where we wanted it to? How do we know it was viable once it got there? How do we know it stayed there long enough? Maybe it stayed there too long. What was the concentration? We've had very difficult times in managing that. But these cells, through surface receptors, talk to each other. and they can have the potential to talk to the native environment as well, the defect, and they can physiologically titrate the amount of growth factors and all the other things necessary for regeneration. And the material that we've been using, doing our research on, is bilayer cell therapy, so that's what we'll be talking about. But again, you have to kind of change the way you're thinking about grafts. When you and I are faced with a defect in the oral environment, traditionally we've had two ways that we could manage it. One is primary intention. You know, let's go in, let's mobilize flaps, let's advance those flaps, let's suture them, or let's use grafts, where we take a graft and we move it in to close the defect. In the past, we also have used secondary intention. You know, just let it granulate in, but that's fallen out of favor primarily because of pain and time and inflammation and all of those things. But you know, even with primary intention, you can sometimes end up with scarring along the scar line, or you can get a tissue mismatch from the tissue you're placing from one part of the body into another part. And whether you're using primary intention or secondary intention, all of them have a spectrum, fall along a spectrum of wound healing. All from, you know, on the worst end, big keloids to hypertrophic scars to tissue mismatches and grafts. We all know that you know, kids heal much better than I would heal. We know that fetuses heal without a scar, and certain animals like newts and salamanders, through a really unusual form of secondary intention, they can actually regrow limbs. So I think our challenge as a clinician is, how do we take what we're doing in the clinic and move it from the scar toward the regeneration area of the spectrum of wound healing? Now, when it comes to regeneration, no matter almost what model, if you think about all the different models out there, no matter what model you're looking at, whether it's neonatal or it's fetal or it's animal models, anytime you see regeneration in those models, it's always relying on secondary intention. Interesting. And bilayer cell therapy doesn't really act like a graft because its products don't hang around long enough. Grafts kind of stay there forever. When you place a graft, those cells are there. In the past, that's been the best we could do, but it may not be the way we want to manage things in the future because there can be problems with these grafts. For example, so we all know the fact that if you're using a graft that you're having to take a remote donor site, you have limitations of the amount of material you can gain, there's morbidity associated with it. But also, oftentimes there's mismatch in color, it doesn't look right, and in addition to that, if you're closing a site early with a graft, you can abrogate the latent regenerative capacity that site may actually have because you've closed it too soon. Well, bilayer cell therapy doesn't work like that. It modulates secondary intention and moves that spectrum toward regeneration, as is evidenced with this patient here with the return of natural pigmentation. Had this been grafted with a traditional skin graft, it would have never looked like that. Well, how are we going to use it in the oral environment? Well, here's one of our patients that we're going to look at later in the study, and we've got a cuspid here with just mucosa. So I've gone in, I've created a traditional little bed for my phrygmatogenous graft. If I'm using this material just to simply make healing more rapid and eliminate scar, what I'm going to end up with is the same thing I started with. But it's just going to heal faster, the wound's going to heal faster without a scar. But that's not the way this material works. This material works by changing the trajectory of healing, actually inducing appropriate site differentiation of the cells. We have now keratinized tissue where mucosa used to be without placing a traditional graft into that area. Using that approach, we did a small pilot study a couple of years ago that was published in the Journal of Periodontology in 2008 in an attempt to create keratinized tissue around teeth that didn't have any. Now, in this study, we're not trying to do root coverage, we're just trying to go in and create a nice zone of keratinized tissue. It was a split mouth design. where we were looking at a number of safety endpoints. We're also looking at some efficacy endpoints. We're looking at the amount of attached gingiva with the keratinized tissue we're able to gain, looking at inflammation scores, color and texture match as it matched the adjacent teeth, resistance to muscle pull, probing depth, all of your normal secondary parameters you'd usually look at, but also some patient-centered outcomes, patient preference or satisfaction, and any change in recession depth. It was a 25-patient study, again, one that we were not trying to cover roots. We're just trying to simply add in keratinized tissue. Now, this is the way that the material looks. It's two layers. On the top layer, you have living keratinocytes. On the lower layer, you have living fibroblasts in the collagen matrix. And these cells, both keratinocytes and fibroblasts do not elicit an immune response. So that's not something that we have to worry about. And the interesting thing about this relationship here is that when you have keratinocytes and fibroblasts together, they're synergistic. If you look at the effect of these two cells when they're together, and you look at all of these growth factors, cytokines here, and just look at the keratinocytes, look at which ones the keratinocytes produce. They produce some, they don't produce others. If you look at the fibroblasts, they produce some, they don't produce others. But what happens when they're placed together? Because of the crosstalk, because of the synergism, when they're placed together, this bilayer cell therapy is producing all of these cytokines. And in fact, it's interesting, the look on the IGF and the interleukin 8, if you have the keratinocytes by themselves, they don't produce this at all. If you have the fibroblasts by themselves, they don't produce that at all. Yet when they're together, they're producing it. And producing an array of cytokines very similar, in fact identical, to human skin. And the neat thing about it in my mind is it is a reservoir for many of the cytokines and growth factors that you and I have already identified as important for periodontal regeneration. It's producing BMPs, it's producing PDGFs, VEGFs, a lot of cytokines and growth factors that you know that we're looking for. Here's a natural reservoir to be able to deliver those to the site of need. Along with that, it's providing a lot of extracellular matrix components, things that are necessary for cell migration, structural integrity, inflammation modulation, collagens, fibronectin, tenacin, all of the things that we need as we go in and rebuild tissues. And it's stimulating angiogenesis. What's one of the things that gets in our way as clinicians every day? Blood supply. When we sit down to do surgery and we have surgical guidelines that we're working off of, what are those surgical guidelines developed around? Blood supply. What if we can go in and regrow our own blood vessels into the area? It has the potential to rewrite the rules of surgery, to rewrite the rules of regeneration. This material is producing VEGF, basic fibroblast growth factor, both which stimulate blood vessel formation into the area. Another problem in the oral environment is the bacterial bioburden that you and I have to work in all the time. If you cut your finger, your body produces in a quick burst a peptide called beta-defensin, but it just goes very quickly and it's gone. This material produces beta-defensin on an ongoing basis, therefore potentially lowering the bacterial bioburden where we need it in the area of regeneration and repair. So another interesting thing. But most interesting to me is the fact that it is a living device interacting with the host. If you look at this response here with these cytokines on days post-insertion, look at how some of the cytokines are actually being delivered at a higher dose, say 4 days, than they were when the device was placed into the defect. Again, that's because the device is interacting with the host. You need a little more of this? Okay, here it comes. You got enough? Okay, that's it. We'll stop. And complete proof that it's a biologically active living device is that if you wound it, it heals. And in fact, in our pilot study, we did wound it because some of the plastic surgical cases that had been done prior to that, they would go in and striate the material because it causes an upregulation of production of certain cytokines. So if you look here, here's the wound through the upper layer. At 0 hours, At 12 hours, you can see the keratinocytes beginning to migrate over the surface. By 24 hours, the keratinocytes have completely covered the surface, and by 5 days, you have a fully differentiated epidermis. Now, we're taking chromosomal material from one individual and placing it in another, so we want to make sure that that comes in, does its work, and leaves. So we looked at, in our pilot study, we did PCR analysis of the DNA of these patients, and we found no evidence of persistence on any of our patients. That also then leads in and is further support that this material doesn't act like a graft. You know, it doesn't stay around. It comes in and it stimulates de novo regeneration of the patient's tissue through modulation of secondary intention. In addition to that, we went in and did biopsies, just standard biopsies, and did H&E stains. These were then evaluated in a blind fashion from histologists, and there was no differences. They couldn't tell any difference between the traditional free gingival graft and the type of tissue we were creating with the bilayer cell therapy, just good keratinized gingiva. We chose to do this in a Z-fold with the keratinocytes on the outside and the fibroblasts next to the periosteum. And we did it primarily because in earlier studies that I had done with earlier generation material, we found that the Z-fold was more effective for a number of reasons, and it just improved handling characteristics. Now this, of course, is what we're trying to avoid. We don't want to have a big area on the palate, or even a little area on the palate that's going to cause pain or bleeding, morbidity, and we want an unlimited amount of donor material. So we're not having to just treat those areas in most need. Now, even we, during the early pilot study, still didn't quite have our arms around what it is we're working with, and we standardized the width of the grafts in the pilot study to be 5 millimeters. You can see here my free gingival graft is 5 millimeters. Well, we also standardized the bilayer cell therapy. But as we moved forward and got a better understanding of how this is working, again, it's not working like a graft. So there's no reason to think that you need to kind of standardize that, because it really doesn't make any difference. This material comes in this bioreactor. It's fresh, never frozen. And I'm about to come in and remove, I'm actually wounding the material here. And I'm just going in, making a couple striations. You could graft the entire mouth with the amount of material that's in this bioreactor. And I'm now just removing it from the little well that it's in. The nutrients that it's growing on are underneath that. And I'm now creating our little Z-fold. I'm just folding it back, and then I'll bring it back, kind of like you would a sheet on a bed, or a letter you're going to put in an envelope. And because the pilot standardized width, we're just making sure it's 5 millimeters wide. And I found the best way to get it out of there was not through a scalpel, but once I had it, to just remove it with scissors. And now we'll pick it up. Now I've already created the bed in the patient. And I'm going to take it over to the mouth, putting it on the bed. And then I simply suture it to the interproximal papillas. So there's our graft. And this is the same patient you just saw. So here is our bilayer cell therapy. Here is the opposite side, the control. At 4 weeks, With our bilayer cell therapy, you're seeing increased keratinization over what we had initially. You're seeing the mucogingival junction beginning to form. The free gingival graft is operating as you would expect. As we go out to 6 months in these panels, we've stained it with Schiller's iodine to further differentiate the attached gingiva from the mucosa. And you can see that we have a nice zone of keratinized tissue, and it's resisting muscle pull. Another patient, here is our bilayer cell therapy, our free gingival graft, and if we look at the panels at 6 months, I think you can appreciate the fact of how much more natural this looks than this. And that's not surprising because these cells will retain their poutal phenotype. They don't really belong there. The bilayer cell therapy is causing cells to come in and populate here, that changing the trajectory of healing with cells that belong there. So we looked at all of these parameters, compared it between the free gingival graft and our bilayer cell therapy graft. We looked at width of keratinized tissue, probing depth, recession, clinical attachment level, inflammation, healing time, changing color and texture, resistance to muscle pull, and subject preference. And the only variables that were different between the two grafts in a significant way were these three. And if we look at each one, as far as width of keratinized tissue, the free gingival graft beat the bilayer cell therapy by about twice. We generated about 4 millimeters of keratinized tissue with the graft, free gingival graft, and 2.4 millimeters with the bilayer cell therapy. We concluded, however, that the bilayer cell therapy was safe and capable of creating de novo, without a donor site, up to 4 millimeters of keratinized tissue. 24 out of 25 of our test sites demonstrated an increase in keratinized tissue, and 3/4 of the sites yielded 2 millimeters or wider bands of keratinized tissue. When it came to change in color and texture, bilayer cell therapy won out. Again, because it's not operating like a graft, it's creating regeneration using the patient's own tissue. And the final area of significance, you can guess which one the patients preferred. Now, because of the positive results of the pilot study, we then moved into a larger multi-center trial. These are the centers, our office with myself and Todd Shire, University of Texas at San Antonio with Drs. Cochran and Melanig, Michigan with Dr. Navin, Ginobili, and Morelli, and then Martin Evans in Boston. Our primary efficacy parameter in our large trial, our multi-center trial, was creating keratinized tissue greater than or equal to 2 millimeters. We looked at a lot of secondary endpoints, among which were color and texture, patient preference, surgical site sensitivity, and pain after 3 days, and a variety of additional efficacy endpoints. We found that we achieved in the multi-center trial primary efficacy endpoints. The primary efficacy endpoint was met. We regenerated a mean of 3.21 millimeters of keratinized tissue without a donor site. So we greatly improved the amount of keratinized tissue we were generating from our pilot study to the multi-center trial, and we had no safety issues. If you look at the secondary efficacy endpoints, the bilayer cell therapy was superior to the free gingival graft in color, in texture, and the patients expressed a strong preference over the free gingival graft, taking into account all aspects of treatment, surgery, recovery, appearance. Just to give you a look at this, because it looks a little different from the pilot. You've got a tooth with just the mucosa here, and here's our bilayer cell therapy. This will be the control with the free gingival graft. And you see here a nice zone of keratinized tissue, very comparable to what we got with the free gingival graft. Another patient, this is our bilayer cell therapy, before the bilayer cell therapy, before the free gingival graft. Very equivalent zone of keratinized tissue with the bilayer cell therapy. You can see it's resisting muscle pull. And then the last one I'll show you again, bilayer cell therapy, free gingival graft, and the endpoint. I really think that this is possibly a historic moment in surgery, in that, this is a very functional result. This is what you and I are used to looking at. This works, but is that really what we want? I think it's time for us to move on. We want to go to the point that when we do our grafts, we're creating something that is indistinguishable from what Mother Nature intended. Look at this. First, look at the pre-op. You can appreciate with the vascularity here that this is pure mucosa. Look at this. If you were to look at this, could you tell anything had ever been done there? I don't think so. And I think that's where we're moving in the next generation of grafts. So with this, we concluded that bilateral cell therapy is effective and well tolerated in a non-submerged wound healing environment. It generated more than 3 millimeters of new keratinized tissue, provides improved aesthetics, greater patient preference, there wasn't any donor site morbidity, and this package is going to be taken to the FDA late this year or early next year. We're also doing a small trial looking at this in a submerged environment for root coverage. And it's a 26-patient study that we're in the middle of right now, where we're placing the material with varying layers, 1, 2, 3 layers, and submerging it in an effort to see what we can do as far as root coverage as well. Well, let's move now on the tissue engineering spectrum, leave the live cell end and move over to the biologically active molecule end and spend the rest of my time talking about platelet-derived growth factor and beta-TCP. We published a paper in 2006 in the International Journal because we were fortunate because we were one of the sites in the pivotal trial for PDGF in the interbony defects, and I was really impressed with the results of that. And with my interest in soft tissue, I said, okay, let's see if we can leverage that to cover root surfaces. So we started with a small pilot, and our primary efficacy parameter was just an absolute change in recession depth, but we also looked at attachment level, probing pocket depth, amount of keratinized tissue. The test components were the beta-TCP, which it's an active material. It's used a lot in orthopedic surgery. It's biocompatible osteoconductive scaffold for bone formation. It prevents soft tissue collapse, facilitates stabilization of the blood clot. But the real workhorse is the PDGF. This is a cell signaling growth factor. We probably know more about this growth factor than any other growth factor in periodontics. It's mitogenic chemotactic for PDL cells, for bone cells, and it's angiogenic. It causes osteoblasts to produce VEGF. And we used the collagen membrane here because I just was a little worried that the TCP particles might migrate out of my vertical releasing incisions, and so we chose to use that in the pilot study. Well, here is one of the controls. We're going to graft both the bicuspid and cuspid of fairly deep, wide defects. After root surface preparation, a partial thickness flap, I harvest some connective tissue, currently advance the flap, just a typical connective tissue graft like all of you would do. Here we have the results at 3 months. Excellent root coverage, 100% root coverage, a little stain from the Paradex. Same patient, opposite side. This will be our test site. And we're going, again, a fairly wide, deep defect. After root preparation, we have a full thickness flap this time because we're going to try to actually grow bone here. So it's full thickness, about 2 to 3 millimeters beyond the osseous crest here. I'm placing a little PDGF on the root surface. I've already hydrated the PDGF, and now I'm placing it over the root surface, extending it onto the bone, just about a millimeter or so, but trying to stay away from the vertical incisions. Now I placed our membrane, our collagen membrane, tacked it in approximately, hydrated it with some more PDGF, and currently advanced and closed the flap. And here is our graft at 3 months. Again, I think it's a very nice end result, 100% root coverage, very aesthetic, no visual signs of inflammation, less than 2 millimeters probing depth. And if we compare the two at 6 months, very equivalent results. Beautiful root coverage, nice aesthetics, everything I look for in a graft anytime that I'm doing it. And just to let you see another one of the grafts we did in the pilot, this is the connective tissue graft, and this is the currently advanced flap with the PDGF. So again, a very nice end result. That then we concluded with the pilot that both of these procedures, they worked basically. And because they worked, it served as proof of principle that this is something we might want to look at with a properly powered study, and that's what we did, and that we published just a few months ago in both International Journal of Perio and Journal of Periodontology. In this paper, we looked at both clinical parameters as well as what type of attachment are we gaining. Because, you know, I'm a clinician and I want to know what's the value added here. I can cover roots all day long with connective tissue that doesn't cost the patient anything. What am I getting here if I'm adding a biologic to the mix? So this is a 30-patient study. 6 months. Our primary efficacy parameter was recession depth. We looked at all of these secondary efficacy parameters, and the only significant differences we had between the two at 6 months were these three: recession depth, percent root coverage, which are really the same thing, just a different way of expressing them, and pain and discomfort. If we look at percent root coverage, with our coronally advanced flap and our PDGF, we achieved about 91% root coverage. With our connective tissue graft, we achieved about 99% root coverage. Now, I think it's important to have benchmarks when you look at these things. And if you look at the systematic reviews, if you look at the meta-analysis that are out there, they'll tell you what you should expect with different things. And with Miller Class 1 and 2 recession, which we have here, the meta-analysis tell you you should get about 89% root coverage with a connective tissue graft. Well, we're getting about 99. So the problem is I do too much of this, I'm getting too good at it. It's skewing our results. So if you look also at these meta-analysis and you're just using a coronally advanced flap, you should get about 82% root coverage. Well, we really knocked it out of the park. We're getting about 91% versus 82. So I think it's important to look at what the averages might be. I think that couches these a little bit better. And also interesting, even though if you look back there's almost a 9-point difference here, our patients thought they were equal. So either our patients are not quite as obsessive as we are about these things, or they saw so much improvement that they thought, hey, that looked great. And finally, pain and discomfort, you can imagine again which the patient preferred. They don't like the palate. Now, we've changed our technique a little bit. We're just marking at the CEJ with a pencil for photographs. After the same type of full-thickness flap, I'm placing a little PDGF on the root surface. We've hydrated the TCP, placing it on the root surface, but we're putting less TCP. Remember on the pilot I showed you a big pile of it here. Now we're placing even less. I just want enough TCP to give me a little space for regeneration, to keep the membrane and the tissue from collapsing, and I'm keeping it about 3 millimeters away from the CEJ to give room for the biologic width, and then staying away from my vertical releasing incisions. Also, from Massimo's and some other people's work, we found after we did the pilot study that, hey, you might not want to be using a cell-occlusive membrane here. And Dr. Reynolds mentioned that in his presentation as well. So in our bigger study, we didn't use a cell-occlusive membrane. We used just a collagen wound dressing that goes away very quickly. And so this is a collagen wound dressing. We've tacked it in approximately. I'm placing PDGF on it. And now we have it hydrated with blood in the PDGF. And I'm placing a little more PDGF after I've sutured because it stimulates wound healing. That's one of the things that PDGF does. Now, this is biosurgery. There's a lot going on there at that root surface. And PDGF is stimulating the cementoblast to come in, the osteoblast to come in from the osseous crest. Fibroblasts, endothelial cells are going to lay down cementum, new bone, organizing a PDL, and over time a new attachment apparatus. Now, it's one thing to draw this, but can we actually achieve this? And we'll see that in just a moment. So here's the result at 6 months. Nice root coverage, 100% root coverage in this case, if we compare it to what we had initially, and if we compare it to the connective tissue control in that patient, very similar results. Another patient, connective tissue, PDGF, nice results on both, a little not quite so bulky here. We also included mandibular teeth in this study. They're more difficult to treat, especially teeth like this that have severe recession on adjacent teeth. And we're not treating those. So here, if you look, this bicuspid here is the final. Very nice result. Also, we got a nice result with the connective tissue also. Now, anytime we're doing root coverage grafts, there's 3 goals. First is, let's reestablish what we need for function and health. I think we've done that. I think everybody would agree. Second goal, let's reestablish what we need for aesthetics. Everybody agree that's a pretty nice looking graft. But it's the third goal of covering recession defects that's the question. What kind of attachment do we have to that root surface? And I'll end with going over the other part of this study, and that is where we with the help of Peter Schupak, we looked through micro-CTs and ground sections to see what type of attachment are we gaining. Now, I was able to recruit 2 patients that needed orthodontic treatment that needed 6 bicuspids extracted. One patient needed 4 bis, and the other patient needed 2 bis extracted. So it gave us a nice ethical way to look at this, what type of attachment. So at day 0, we went in and we created recession defects here. So I did a full thickness flap, I removed bone so that I could then apically reposition my tissue and create recession defects of at least 3 millimeters from the CEJ. I then allowed those defects to become chronic. We just let them hang around in the mouth for a few months without doing anything. And then at 2 months we came in and in a randomized fashion we either grafted with connective tissue or the PDGF. And at 11 months, or 9 months after the graft, we removed these 6 teeth in block, and then the patient went into orthodontics, space is closed, everybody comes out a winner. On all 6 of our teeth, we achieved 100% root coverage. But regeneration was very different. We had regeneration in 4 of our defects with the PDGF, 2 of the defects with the connective tissue. Here's one of my patients that this is our recession defect. I'm marking it at the free gingival margin with a high-speed finishing burr so we can see that histologically. That's that little mark. We now have our full thickness flap here. I'm marking it at the osseous crest again. Here is at 9 months after that point, after the graft, we have 100% root coverage, and we remove the tooth in block. Note, this is our micro CT. So here's the tooth. You're going to take an x-ray of this tooth, a micro CT. We're looking through it. Look at the new cortical bone growing down over the root surface. You can't see the notch at the alveolar crest because it's up here someplace. If we rotate the tooth around, that little dimple is that notch, and that is that. Now, again, an interesting thing is we got bone growth, we got as much as we could get. At first, when I looked at it, I said, well, why aren't we getting it further down? But you have to remember, I made these recession defects were 3 millimeters. So that mark there is 3 millimeters. How much room do you need for your biologic width? About 3 millimeters. So biologically, there's really no way we could have grown any more bone than what we grew. And if you look at enhanced micro-CTs, the white is old bone, the red is new bone. You see the new bone growing down over the root surface. You see new cementum. You see a uniform space for the PDL. Pretty amazing. And we didn't grow just a little bone. We grew a lot of bone. You know, if you go and you look in the literature, at all of the literature out there on what type, do you or don't you get attachment from a variety of different ways to cover roots. And it's all over the map. And then if you look at just those studies that report regeneration, very few report how much regeneration did you get. And the few that report it, it's usually in the 0.5 millimeter range. We're getting 2 to 3 millimeters of new bone here. So again, not just statistically significant, but clinically significant as well. You can clearly see the old bone up here. You see the new bone coming down the root. This is some residual TCP. We found this to be a problem with a number of the patients. It seems the TCP was not all resorbing. It may have been keeping our graft from being quite so robust. But clearly, I mean, this is the old bone. You see the new bone. If we look at this area here, we've got our bone here. This is new cellular cementum. So here, these are osteocytes, woven bone. Here's Sharpie's fibers, functionally oriented PDL, Sharpie's fibers, cementocytes, new cementum, old cementum, dentin. And in polarized light microscopy, dentin, old cementum, new cementum, Sharpie's fibers, PDL over to the bone, Sharpie's fibers, new bone. No doubt we have achieved all of the things we need to say we are getting true periodontal regeneration. And we did it every time. Here's another one of them. We removed the tooth in block. Here is our notch at the alveolar crest, which was 3 millimeters. Our regenerated osseous crest here was almost to the notch at the original free gingival margin. Here's our long junctional epithelium ends right here. So again, if you think about it in the concept of the biologic width, your sulcus, junctional epithelium, and connective tissue, we got as much bone as the body's going to let us have right there. And if we look at it in high power, at this area right here, again, here's your PDL, new cementum, new bone. Here's our dentin, old cementum, new cementum, Sharpie's fibers, PDL, new bone. Another one, PDGF, new cementum, functionally oriented PDL, Look at those Sharpie's fibers. I mean, you're not going to peel this sucker off of there. Polarized light microscopy, bone, functionally oriented PDL, new cementum. Here's one of the controls, connective tissue graft. Look at the micro CT here. Absolutely no activity. Here is the little mark at our original alveolar crest. Here it is there. For the first time, we can see that. We couldn't see it with any of the PDGF ones. And if we look here, we've got our long junctional epithelium running almost to the osseous crest, just parallel connective tissue fibers, absolutely no activity here whatsoever. I think this really tells the story. If you look at the micro CTs of the teeth we covered with PDGF, look at all the activity on the root surface. Look at the dead micro CTs over here on these teeth. And finally, remember this guy in the pilot study? Well, he came back to my office 3 years later. He had a periodontal abscess right back here on the molar. At 3 years, we're maintaining good root coverage, good aesthetics, and I talked him in, could I take a little peek since we were going to be in the neighborhood. At 3 years, we note that we have 2 to 3 millimeters of supporting bone growth in a naturally occurring recession defect. I showed you surgically created recession defects, and here I'm showing you a naturally occurring recession defect with a similar result. I hope you share my enthusiasm that it's never been a better time to be a periodontist or a patient in need of our services. The things that we can offer our patients are revolutionary. Thank you very much for your attention.